patient disappears and anti-epileptic drugs could be stopped. These are cholesterol levels in the follow-up of 14 children, and the longest follow-up is 7 years for monitoring the cholesterol levels. And this is an example of an MRI of a child, and you see here nearby the internal capsule very small hyperintense signal on the T2 MRI. So the classical MRI picture, which Professor Federico demonstrated in adult patients, it's not found in children. They could have abnormalities, but are very small abnormalities, very minor abnormalities. Well, I corrected these, but it's the right presentation. That must be 19 and 12. Those are the wrong numbers. But these are the adult patients. The treatment has started after 21 years, with a treatment duration of 12.5 years. And in this group we saw that also diarrhea disappeared in most patients, and most patients had cataract extractions, but the neurological symptoms and signs did not disappear and even become worse. And the present symptoms and signs in most adult patients, in a large part of the adult patients, were progressive, particularly the gait disturbances. In more than half of the patients, they were progressive despite the CDCA therapy and the compliance to the therapy. Well, the literature about this subject, Gilad Yahlon from Israel published in 2013 a study of 18 CTX patients out of 11 families, and 16 of them were included in the analysis. 10 of them were treated before the age of 25 and 6 were treated thereafter. And they concluded also that a relatively late start of therapy results in significantly more limited ambulation and more cognitively impaired patients. And also they confirmed that their patients deteriorate despite the CDCA therapy. Well, in children it's different, and these are 2 patients from Israel published by Vladimir Bergen in Pediatrics in 2009. One patient 2 years and one patient at the age of 7 years diagnosed with diarrhea and cataracts. The treatment duration in these 2 girls was 14 years, and in patient 2 there was suboptimal compliance. I think the daily dose is high, and I doubt whether this is the dose that had been started in those girls, but I think they're now on 750 milligrams daily. And in both patients, the CTX phenotype was prevented after a follow-up of 14 years. So to conclude, I think that early treatment, like Professor Federico told it already, can prevent the CTX phenotype. In very young patients, CDCA daily dose of 5 milligrams per kilogram may be safe and results in normalization of the biochemical phenotype. And I think that newborn screening is feasible but needs validation. And my last slide is an acknowledgement slide. I collaborate with the Radboud University Medical Center and with the Academic Medical Center in Amsterdam and the Medical Center in Utrecht. Thank you very much.
Wonderful. Thank you so much to you, Dr. Harris, for making it so clear and so short. Nice. so we can now get back to being in time. And now we have Dr. Olivier Bonnot. Excuse me if I don't pronounce your name correctly. He's an expert in pediatric and young neuropsychiatry. So welcome and thank you also. And now we will focus a little bit on what has been mentioned already. The psychiatric manifestations of this disease and what do we know about them and how can we treat them. Thank you again.
All right. Thank you for this kind invitation. And I'm sorry not to be able to speak in Spanish, so I have to speak in English, which is also not my native language because I'm French. Sorry.
Ahora sí, ahora sí, ahora sí.
So, very pleased to be here. I'm the only psychiatrist, which is something I used to in this field. As you know, maybe, I don't know if it is the same in Spain, but usually psychiatrists are not very interested in organic disease and moreover in neurometabolic disease. I was for 5 years the leader of a very special center in France, a rare disease center for psychiatric symptoms in rare disease. It was the only one. We made a lot of work to be accepted by authorities and our ministry. It was a lot of work, but we were supported by family groups because we think there are a lot of work to do with patients with organic disease in general and in neurometabolic disease in particular regarding psychiatric aspects and symptoms. By psychiatric symptoms, I always think about psychiatric disease like schizophrenia, ADHD, which is hyperactivity, or bipolar disorder, depression, but also in what we call learning disorder, instrumental disorder, meaning difficulties to learn to speak and to write and to read, things like that, or attention disorder. But also we are interested in intellectual deficiency, which is very, which suffer from a lack of extensive examination and exploration and assessment, and we are in this area. So I will make a little presentation about CTX in psychiatry. because I was very interested because CTX is the origin of my interest in neurometabolic disorder. The first patient I saw with psychiatric symptoms and neurometabolic disorder was a CTX patient. So I'm very pleased to be here and to speak about it. But also I will speak about neurometabolic disease in general, because I think that many patients with psychiatric disorder suffer from a lack of examination, of organic examination, organic assessment, and maybe some patients could have organic disorder, and especially neurometabolic disorder, untreated. And I think it's a very high-risk population for this kind of disease. So it's really a growing subject in psychiatry, and but it's recent. We made a lot of work about organicity in psychiatry many years ago, but for decades it was not very interesting for psychiatrists, maybe because psychoanalysis was the leading thinking in psychiatry, and we had to separate organic disorder from psychiatric disorder, which is, I think, not very relevant. Not that I think that psychiatric disorder are all organic disorder, but I think that psychiatric disorder may be organic disorder, and it doesn't change anything. It doesn't change anything for the patient, because we have to take care of the patient and psychiatric signs of the patient, and to help them also with medication, and also with psychotherapy or anything we do. But also, I think that if patients have organic disorder, it doesn't really change the way we can understand the psychiatric disorder. For a lot of time also, because I say bad things about psychiatrists, and right now I can say also that organic disorder had a very poor description of psychiatric symptoms. And when we look at the literature, we see that patients with neurometabolic disorder, there are some large case series of these patients, but psychiatric description is really poor for psychiatrists. When somebody is just a little bit sad, it's written it's a depression. When somebody is just a little bit strange, it's written it's psychosis. And when somebody is a little bit agitated, it's written like, it's described like ADHD. So for us, it's not really the same. We have really clear categories and symptoms, and it's very important because we may distinguish, for example, if you have a CTX, you may diagnose CTX, you may be sad. It's a normal response, a normal reaction of your mind. It's not always a depression, and it doesn't say that depression is associated with CTX for maybe biological reason or things like that. It's very important to distinguish these two lines and these two fields. And we know that we have a lot of, here you will see main association between schizophrenia, for example, and organic disorder. We know for a long time that there are many diseases which may be associated with schizophrenia, neurological disease, but also infectious disease, autoimmune disease, endocrinologic disease, and of course neurometabolic disease. On this table you will see only the diseases which are treatable, because there are many, as you know, neurometabolic disease, and we usually focus on diseases which are treatable because it's more interesting for the patient, and there are too many, we could not search for all. But we all know that there are many diseases associated with schizophrenia. We also know there are many diseases associated with autistic disorder. Here you will find the main. What is important is that you have a part of patient, if you take Fragile X syndromes, for example, you have part of patient with TSA, which is autistic spectrum disorder. Sorry, it's in French. Autistic spectrum disorder. You have 2 or 5% of all patients with autistic disorder having Fragile X syndrome, but you also at the same time having 20 to 40% of all patients with Fragile X syndrome having autistic disorder symptoms. So here you find on this table some of the main disease associated, and on the second table you will find main disease associated with main neurometabolic disease associated with autistic symptom. As you see, many of them are treatable, and also there are many neurometabolic disease associated with autistic disorder. It's very important because we don't usually search them, all of them, and so some patients maybe have treatable disorder. I just want to remind you a very recent article from a colleague in British Columbia, Canada, who found 82 treatable neurometabolic disorder in patients with intellectual disabilities. And like I said, most of these treatable disorders are not currently searched, and so all my commitment is to convince people, like you are convinced, I think, most of the psychiatrists are not, to search for this disease, even if you don't find many of them. If you can treat them, it changes everything for the course of the life and the history of the patients. So it is also important to understand that in some cases, not all cases, but in some cases, psychiatric symptoms may be the only symptoms presented by the patients. It happens many times, and it is very tricky to think about organic disease and to think about a neurometabolic disease if you don't know. And you will see for CTX there is no specific science, specific psychiatric science to trigger you to search for a neurometabolic disease, and especially CTX. But I will present you very briefly some atypical signs in psychiatric patients who may trigger us to search for organic disease and for neurometabolic disease. By organic disease, I think about genetic disease mostly, because genetic disease start in newborns, even if the onset may be a little bit, the clinical onset may be later. So it's very important for psychiatrists to have clinical psychiatric signs, atypical psychiatric signs they can search, because usually psychiatric practitioners are very good in clinical medicine, because we only have clinical aspects, as I saw earlier, and I know it. You have many biological, neurological, or MRI and things like that examination to help you. We don't have anything. We just have a clinical aspect. So we know very much about clinic, and we know that some patients have atypical signs, and these signs must be known by all psychiatrists to refer after to somebody with more specialized skills in neurometabolic disease and organic disease. Also, we know that psychiatric patients, and especially patients with intellectual disability, have less examinations than other patients. It's very well known. It's very sad, because it's kind of double lack of chance, because you have a disease, intellectual disability or psychiatric disease, and more, you have less chance to have examination by a specialist to find if you have another disease or an associated disease. So there is a need, that's my whole point, for an extensive search of neurometabolic disease in psychiatric population. And it's very difficult because we don't know very much the prevalence of the disease. It's very difficult to search in a whole population for all the disease. We have sometimes very subpopulation of patients where we extensively search for disease. For example, in early onset schizophrenia, which is quite rare, we search very extensively, and most of the team found around 20% of patients with organic disorder associated. It's the same in catatonia, which is also rare, and we found catatonia in young children is mostly related to schizophrenia, which is much different than in adults, where it is related to bipolar disorder. But in early onset catatonia, because I'm a child psychiatrist, we found also between 15 and 20% of patients with organic disorder. Not all neurometabolic disorder, also sometimes lupus, something like that, but it's a large amount of number of patients. But we don't know in general population of patients, for example, with schizophrenia, on bipolar disorder, or autistic spectrum disorder, which are, as you know, 1% of general population for each disease. It's a very large amount of patients, so it's very crucial that we add signs, specific signs, to encompass a small part of this population for having extensive search of disease, and that's why we think about atypical signs of psychiatric signs. Okay, let's go to CTX, which is the main topic of the day. There are not a lot of literature regarding psychiatric signs in CTX for many reasons. First is because there are not so many patients with psychiatric signs, and also because usually psychiatric signs are not very well described, and so we cannot use the literature in all aspects. But we made a large review of literature with a colleague of me, a Greek one, named Fredakis, in 2004, between 2012 and 2004, and we found about 300 descriptions of patients in all literature of CTX, and in this large amount of patients, we found 10% of all the patients with psychiatric signs very well described, and so maybe not in the first aspects of the symptoms, but with large psychiatric symptoms. In childhood patients, you will see that we distinguish what are behavioral disorder, which is not very specific. What is behavioral disorder? For us, all psychiatry is about behavior, so all psychiatry is behavioral disorder. But most of this article describe behavioral disorder like as aggressivity or things like that. For all of the patients, of the 30 patients described in childhood, psychiatric symptoms were behavioral disorder. In adolescence, it was not all of them, but just part of them. In early adulthood, it changed a little bit, and in late adulthood, behavioral disorder were very low. So that's very important, because you have atypical signs, aspecific signs, of behavioral disorder in patients, in childhood patients, also in adolescent patients, and more you grow, more your age, and more appears different kind of disorder, many kinds, like psychosis, which is not very well described all the time, but also catatonia in early adulthood, and also depression, in adulthood and early adulthood and late adulthood. That's important because you may know and you may remember that in CTX, the more late in age you are, the more various symptoms of psychiatry you may have. If you distinguish between psychiatric onset and not psychiatric onset, you will see that behavior disorders are more frequent in patients with psychiatric onset than in patients with no psychiatric onset. Meaning that if you have just psychiatric signs, psychiatric onset, it's more often behavior disorder than other than if you have no psychiatric onset, and it will be all kind of various psychiatric symptoms. It makes something, it's very difficult so to have a very clear idea, and it make the diagnosis from psychiatric onset very difficult in CTX, like in many of neurometabolic disorder. So I don't come here with very easy solution at this problem. So I will present you very quickly a clinical case, which was, as I said earlier, the case I start with in my interest in neurometabolic disorder. It's, and we publish it in CNS Spectrum, I think 2012 or something like that. It's a patient I discovered. He was 18, but he had a history of psychiatric disorder, a very long history. It's very classical history of patient in psychiatry, and as you will see, there is very few trigger signs to think about a neurometabolic disorder, and moreover to CTX. He has at age 6 very slight tendency to fall frequently, as well as clumsiness and in writing and fine movement. But as you know, maybe a lot of patients have dysgraphia, difficulty to write when they are 6. It's very important. I don't know if it is the same in Spain, but in France, teachers are still very interested in writing. But even if now we don't write so much, but they are very interested in writing. So we have a lot of patients with dysgraphia needing to have sometimes a special treatment for that and write a lot. So it was not very atypical. So impairment were in drawing, writing, and also its spelling and mathematics. As you know, dysgraphia is often associated with dyscalculia, and so it was not surprising also. He also had a diagnosis of hyperactivity, more from the impulsive mode, and sometimes he was a little bit violent with his friends. Early development was unremarkable at this stage, and he was in regular school, and he could learn, even if it was a little bit difficult, and behavioral disturbance didn't allow, he could stay at school. At age 13, so 7 years later, he was hospitalized in a day facility, psychiatric day facility for aggressive behavior toward his mother. It was not just a little aggressive behavior because he tried to kill his mother at age 13, so he was very violent. He was so admitted for a day hospital for 4 years with scholarity inside, so he was outside the regular scope of school. The diagnosis at this time was borderline intelligence because he benefited of risk examination, with dysgraphia still, ADHD predominant hyperactive impulsive subtype, and also oppositional defiant disorder, which is nothing more than not to be very kind with parents. It's so a classical history, There are many patients of this type in my practice of every day, and there is nothing to distinguish from him from other patients. Organic symptoms found in history, because it was retrospective thinking, were just, usually when I present this case, it's in a general neurometabolic meeting, so it's uneasy. Here it's blood CTX, so you know already what it is. He has a pes cavus at age 13, he had a bilateral anterior tarsectomy, and he also had a chronic diarrhea, which is a very important sign, because when you have a chronic diarrhea, it changes your